Okay, thank you very much, Frank. It's a great pleasure to be here. I come from South Carolina, along the East Coast of the United States, and I'm originally from New York and moved to South Carolina about 25 years ago, worked with Jeff Riley, and we're right on the Atlantic Ocean. It's a beautiful historical town in South Carolina. It was voted the #1 city in the world. It's hard to believe, but and this is our College of Health Professions, where we have our perfusion school. Recently, we were in the path of a very large hurricane, a hurricane that almost came to Charleston, and fortunately it diverted away from us a little bit, but we still ended up with major flooding in our downtown area, and you can see the kayaks going through the city market downtown. So today I have a pretty long title, Questioning the Gaps in Perfusion Technology, Physiology, Related Research, and Recommendations and Directions for Future Research. It reminded me of I was supposed to talk about the research gap, and it reminded me of the gap and the signs when you go to London, Mind the Gap. So I've shortened the name of my talk to Mind the Gap, to mind the gap of scientific information that we need to continue on in our research areas. So what's the big question? The question, is it really, what are the research gaps and how to identify them? The bigger question is, how do we come up with research ideas to develop new technology and techniques to improve care for our patients? And that's what I want to address today. So I'm going to talk a little bit about, define what a research gap is, talk about the processes used to find research gaps in the perfusion profession by looking at trends in current literature, looking at using various library tools, and looking at systematic reviews and guidelines. And then finally, at the end, talk a little bit about disruptive technology and how searching only for research gaps limits innovation. So a research gap is defined as a research question or problem which has not been answered appropriately or at all for a given field of study. And the research gaps are important because that's what makes your research publishable. It shows that you're not just duplicating what's already been published, but it shows you have a deep understanding of the status of the body of knowledge in your chosen field. And it shows that you've conducted research which fills a gap in the literature. So we can look at various publications. Usually in publications, the introduction session has some reasons why the research was done, and the conclusion session may actually say areas that lack investigation or need closer examination. We can look at systematic reviews, and they provide a high level of evidence, but they also provide information on what areas do not have a high level of evidence. And then guidelines are developed through review of the literature using very strict methodologies. And they define practices, and Frank was talking about that earlier, about how guidelines have developed in the United States, and I'll talk about that in a couple of minutes. And finally, review papers. Sometimes they also identify fruitful and promising areas for future research. So in order to identify gaps in the scientific literature, we actually did an inventory of papers published in the last 3 years in both the Journal of Extracorporeal Technology and Perfusion and the tiny perfusion letter, which I'm sure many of you are familiar with. And we categorized those papers in an Access database according to the Consensus Curriculum for Perfusion Education. So the Consensus Curriculum for Perfusion Education is a curriculum that has been designed by all the perfusion educators in the United States and has been adopted by the Accreditation Committee for Perfusion Education. And that outlines what we're required to teach in perfusion schools. So in order to have evidence-based teaching, what we did is we linked the papers that have been published in the last 3 years to the perfusion curriculum. And we have a database where you can search through under different areas in the curriculum. So under basic science, there were 43 papers, cardiopulmonary bypass, 94 papers, and mechanical assist, 13. And this is the grand total of 178 papers in the last 3 years that we categorized. So just to give you an idea of some of the areas where most of the literature is being published, myocardial preservation under basic science had a large number of papers, and under cardiopulmonary bypass, the major areas were blood conservation and bypass techniques and conduct of bypass, a very large area also. So that gives you an idea where the research is being published in perfusion. So looking at how evidence-based perfusion is, this paper you may be familiar with from 2002. And this author, Bartels, said the scientific data concerning the effectiveness and safety of key principles of cardiopulmonary bypass are insufficient in both the amount and quantity of scientific evidence to serve as a basis for practical evidence-based guidelines. This paper was really a call to action, saying, reviewed the literature and said there wasn't enough evidence for what we do on a daily basis in perfusion. So that stimulated the development of the International Consortium for Evidence-Based Perfusion. And Donald Lukoski, who is an epidemiologist, not a perfusionist, but is an epidemiologist and has very close ties to the perfusion community, he helped create this international consortium, which eventually became part of AMSECT. And he stated in this article, in his editorial, the creation of evidence-based guidelines will identify areas of practice of bypass that are lacking in sound evidence. So one of the best ways to find gaps in the literature is to look start to develop guidelines. And as you develop guidelines, you see what the level of evidence is. And if the level of evidence is too low, those are the areas that are fruitful for research. It will be responsibility of perfusion at large, once these areas have been identified, to prioritize and subsequently fill these gaps with new and sound research. So this is in 2006. So my presentation is kind of in chronological order. After 2006, this international consortium adopted the American College of Cardiology and the American Heart Association have a task force on practice guidelines. And this guidelines and statements article you can find on the internet, and it tells you exactly how to write guidelines, and very, very strict methodology for reviewing the literature and for classifying the literature and for writing guidelines, and that's what the International Consortium follows. The first article came out in 2006, which was an evidence-based review of practice of bypass, which focused on neurologic injury, glycemic control, hemodilution, and inflammatory response. And this was a major breakthrough to be able to look at different levels of evidence related to bypass in these areas. The next guidelines that came out, there are two related to blood transfusion and conservation. You're probably familiar with these Society of Thoracic Surgeons practice guidelines in 2007 and 2011. And actually, they didn't really make any recommendations as far as research, but if you do look at the if you do read the papers, there are areas where there are low levels of evidence, and those are the areas that probably are most ripe for research. So AMSECT, the American Society of Extracorporeal Technology, developed new standards and guidelines starting in 2011 based on a review of the literature, and the International Consortium for Evidence-Based Perfusion helped develop these guidelines, and by 2013 they were adopted by the AMSECT, the body of AMSECT members adopted and approved it in 2013. So the other area that I looked at was to look at guidelines and review papers related to cardiopulmonary bypass, and I used this a library tool called Scopus, which looks at citations and number of citations, and I did a search related to bypass and systematic reviews and consensus statements and guidelines. And you can see over on the right-hand side here that practice guidelines have very high number of citations, so it's easiest way to find guidelines and consensus statements is to look through a database like this by Scopus. So one of the first ones I found in 2012 was protecting the infant brain during cardiac surgery, which was a systematic review. And I was kind of surprised. The only out of the 4 areas that they looked at, blood gas management, hematocrit, use of NIRS, and deep hypothermia and circulatory arrest, low flow perfusion or regional cerebral perfusion, the only area that had any high level of evidence was in hematocrit, and said avoiding extreme hemodilution, the hematocrit should probably not be below 24%. There was no superiority of alpha stat versus pH stat. There was no, the data concerning NEARS and neurodevelopment outcomes are limited in quality, and among the 3 commonly perfused strategies employed for neonatal perfusion and deep hypothermia, none is clearly superior. So there's not very high level evidence in those 3 areas. So we actually, there was another study that came out in 2016, which was kind of related to this, and it looked at variation in perfusion practice, neonatal versus an infant aortic arch repair, and looked at the difference between using deep hypothermia, circulatory arrest, or regional cerebral perfusion. And they're really, deep hypothermia versus regional cerebral perfusion strategy were used regardless of age or weight. It was adopted without any significant data that supports any better outcomes, yet 43% of aortic arch repair infants received a regional cerebral perfusion. So it didn't show that there was any superiority of regional cerebral perfusion, even though many centers have adopted that treatment. We actually looked at that area ourselves. We looked at the association between cerebral protection and attention deficit hyperactivity disorder. Normally in the population, ADHD has an incidence of about 5 to 7%. Cardiac surgery patients is a little bit over 30%. And we were hoping to show a difference between cerebral perfusion versus circulatory arrest between those 2 groups, and we were unable to show. We found insufficient evidence to show that either deep hypothermic circulatory arrest or regional cerebral perfusion decreased the risk of ADHD. And we looked at this in a group of patients up to between 5 and 15 years after their surgery as neonates. So there's a lot of areas in pediatric perfusion that need to be researched related to pH-stat, cerebral perfusion, and NEARS. This is in adults. Basically, this looked at outcomes in adult patients after cardiac surgery, and they made 2 recommendations as far as, one is that the neurologic deficit after surgery has been reported to be between 7 and 80%. So that's a problem right there, because there's the way that a neurologic deficit is defined is so broad that it's very difficult to compare papers and do meta-analysis. So one thing they recommended, that there definitely has to be a baseline neurologic assessment for patients, and the same test should be used to measure, judge the degree of impairment, so that these papers can be put together and into a meta-analysis. So, and also they found that they had a large number of patients that had pre-existing silent brain infarctions, which could contribute to poor post-op outcomes. So there was not a lot of really good information in terms of outcomes after surgery, because the types of tests that were being used and the lack of baseline data to evaluate it. This was in 2014. This paper came out looking at systemic inflammatory response to bypass, and they showed that there's been no systematic evaluation of literature covering the complete range of inflammatory strategies employed. So previous evaluations were limited to meta-analysis for a single intervention. So they looked at biomarkers such as IL-6, IL-8, tumor necrosis factor, neutrophil elastase, and complement C3a as the most commonly measured biomarkers. But really in the future, and even though they showed improvement, they didn't show improvement in clinical outcomes. So they showed some of these biomarkers showed differences between techniques that were used, but there wasn't an improvement in clinical outcomes. So they recommend that combinations of treatments should be used, and this is an important area for future research. Instead of individual types of mechanisms, treatments to reduce inflammatory response, that it should be combined into to get better results. This is an interesting paper on temperature after bypass. What is the optimal temperature for weaning for bypass? Although it seems much of the literature supports hyperthermic separation from bypass, hypothermic patients had increased mortality, more transfusions, increased intubation time, and longer ICU stay. So, and we all know hyperthermia is related to a neurological injury. So in the absence of specific recommendation, the choice of temperature for weaning should be balanced between the avoidance of cerebral hyperthermia and the minimization of coagulopathy and transfusion. So this paper said no recommendation for optimal temperature for weaning from bypass may be made due to inconsistent published evidence. So that's a huge area for research right there. Pulmonary complications occur in about 10 to 25% of patients. Two areas that looked like good areas for research. One was pulsatile perfusion may reduce inflammatory response and preserve some pulmonary indices, but whether this has relevant clinical outcome is not clear. And also blood transfusion, increase of postoperative pulmonary complications and infections increased by 27% per unit of transfusion. So research into reducing blood transfusions and its association with pulmonary injury looks like a really good area for research. This paper looks at anesthetic management during bypass. They said that there's a lack of standardization in vaporizer integration into the bypass circuit. Many of these studies were performed years ago. Hypothermia on drug clearance may not be as significant as initially reported. There's been no new studies on biocompatible circuit coatings with unknown pharmacologic implications, and they talked a little bit about MEC and an amount of drug sequestration in MEC. They say that the focus of anesthetic studies during bypass have been primarily directed at amnesia. Very little has been published regarding analgesia, and there's no measurement of analgesic depth on bypass. They said there's no regulatory oversight of bypass circuits or oxygenators with the use of volatile anesthetics, and several areas for future research evaluating anesthesia drugs on biocompatible circuits, development of anesthetic and analgesic monitoring device, and a way to standardize all perfusion circuits. I'm sure all the perfusionists love to hear that. Platelet transfusion, this area, the clinical practice guideline for the American Association of Blood Bankers said there's weak evidence. The American Blood ABB recommends against routine platelet transfusion only for thrombocytopenia, and there should be evidence of platelet dysfunction, but even that is a weak recommendation. Examining several patients' platelet function at various points during the surgery is a critical area for future studies to consider. And the last paper is extracorporeal circulation for in and out of hospital circulatory arrest. Overall, the survival for out of the hospital circulatory arrest after cardiac arrest was 22%. Only 13% had good neurologic recovery. So what remains unresolved are the optimal patient characteristics, the cost-benefit analysis, age, period of no flow, quality of CPR, time to arrest, and cannulation are all important factors that need to be studied. And also cannulation in the field of rapid deployment, CPR, is another area that we're moving into. Also, future studies can look at outcomes, long-term outcomes, longer terms than immediate hospital discharge up to a year, as well as organ donation potential in non-survivors. So research gap spotting tends to reinforce and challenge any influentialist theories. It doesn't really challenge any assumptions. This paper came up with a process called problematization, which looks at questioning assumptions in order to try to develop new theories to solve problems. And what it does is it look at the literature and try to articulate what the assumptions are and develop alternative assumptions, and then try and solve problems that way. And you know, I think about this, I think about Lilly High and how he came up with the alternative assumption to use to do cross circulation, and how that was really thinking out of the box. And that's what I think we need to do. Research gaps, looking just for research gaps, tends to foster where we're going, but it doesn't really make the big jump that we need to make sometimes to develop new technology. So Henry Ford, and sometimes taking that big leap is called disruptive innovation. Henry Ford once said that if he had asked people what they wanted, they would have said faster horses, and he never would have developed cars. So for the last thing that I would like to talk about is two areas that I think are very important for perfusion research in the future. So one is to develop less hemolytic cardiotomy suction systems. You can see that bleeding is such a major issue in cardiac surgery. And we're still using the same cardiotomy suction systems that we used for the last 40 or 50 years. We haven't developed a way to reduce hemolysis with cardiotomy suction. There's been a few experimental devices developed with fiber optics and with suction controls, but really we haven't made major strides in that area. And instead of treating bleeding, we should be trying to prevent it. Also removing lipids in the cardiotomy suction system. We haven't done a good job with that. And we have injury in the brain that we can measure with the S100B, but we can't really if we can reduce the amount of suction, and we know that in a lot of cardiac surgery we can't eliminate suction. There's been studies that have looked at eliminating coronary suction and coronary bypass, but for most pediatric cases and for complex valve and aortic aneurysm surgery, we can't do that. We've developed cardiotomy reservoirs where we can let the fat settle out, but they're efficient, but a lot of times we don't have the time to do that during cardiac surgery. So I think that's one of the biggest areas that we need to research in the future and develop is to improve our cardiotomy suction system. I mean, when I was going to take a picture of our system that we use today compared to 30, 40 years ago, and how many of us are still driving the same car that we drove 30, 40 years ago. There's no comparison. So we really need to make some big strides and take a big leap in terms of developing new cardiotomy suction systems. The other area, and I was really interested when Dr. Minucci was talking about his hemodilution before, talking about 11% hemodilution and 14% hemodilution. How about 100% hemodilution? That's what we do with neonates. You know, if you take a 3-kilogram baby, put them on bypass, and if our prime is around 250, that's equivalent to putting an adult on bypass with a 7-liter prime. So that's such extreme hemodilution that we haven't really solved that problem. We've tried in a number of ways, but we haven't really solved it. We probably need to get a perfusion circuit below 100 mLs or less to have an impact on reducing bleeding in neonates. We did this one study a few years ago looking at ACTs, which is kind of, it's not as many parameters as a TEG, but we use heparinase during bypass, and with a high prime circuit, a heparinase ACT on a baby is about 50% higher than the baseline ACT. But with a low prime circuit, we can get the heparinase ACT to only about have a 10% increase in a heparinase ACT. But we need to get this down to 0 like we do with adults. Most adults are in the 0 range. We don't really have any difference between heparinase ACT and baseline ACT. So those are the two areas that I think are most fruitful for research in the future. So why don't we have a lot of innovation in perfusion? This article was in the New York Times about 2 weeks ago. And this looks at the number of new companies as a percentage of total companies that are manufacturing in the United States. And in 1980, 15% of the companies were less than a year old. Today, only about 9% are less than a year old. And perhaps the most significant startups, and these companies that have been in business less than a year, startups, play a critical role in making the economy as a whole more productive as they invent new products and approaches and forced existing businesses to compete or fall by the wayside. So my theory is that lack of competition and lack of startups stifles innovation, and that's where we are today in perfusion, that we don't have enough innovation because we don't have enough competition. I'd like to thank you for your attention today. There's a picture of our class. We have 50 students in 2 classes in our perfusion school. We're the second largest school in the United States right now. And I'll just leave you with our students, a picture of our students in the OR. Thank you very much.
Thank you very much, Joe. This was a very nice overview on the gaps. I agree completely that many studies that have been conducted concerning perfusion haven't been well powered or haven't been well designed. And sometimes perfusion issues are just a side effect of another study done by surgeons or anesthesiologists. So really we have to design our own studies. Just to comment on the pediatric neonatal prime, you know that in our hospital in Berlin we have 80 to 85 mils circuit. So actually we get almost there, but we're not there yet. So I agree completely that even though there are some advances, we haven't got the same degree of hemodilution comparable to adult patients. Now, are there any questions or comments from the audience?
I've got a question. You mentioned a large number of gaps. In your or from your experience, which gap is most relevant with regards to the patient outcome, or which of the gaps? Probably every research gap has something to do. But what
I
is
think
the
the
most...
neurological is always the most important. Quality of life. If you're going to look at long-term outcomes in patients, quality of life is the most important thing. So a lot of that is related to neurological. I mean, most of the times we can do the cardiac surgery repair, but if we don't have a good neurological outcome, then the patient's not going to have a good quality of life. So to me, that's the most important thing, is improving quality of life. And so that's my interest is in pediatric perfusion and long-term outcomes, because we do these little babies, you know, a week or two old, and who knows what's happened to them 10 or 15 years. What kind of burden do you place on the parents? If you read about parenting of these patients, you know, they have very high divorce rates. They have a large economic burden. It's a very, very stressful, it's called extreme parenting. And it's very, very stressful, especially, you know, staged operations, getting patients from stage 1 norward to the second operation. Parents have to worry about infection. They have to worry about feeding the patient, and because a lot of them have G-tubes, they don't. So it's very, very difficult. So in the end, we want these patients to have a normal life, and that's why I was interested in ADHD, because I thought that would be a good marker to look at changes. A lot of babies that have a lot of premature babies develop ADHD, and that's related to low blood flow in the brain. So I thought it would, and maybe if we had a larger study, we'd be able to show a difference. But to me, that's the most important thing, is neurological outcomes. And maybe the most difficult to do, but to me is the most important.
Thank you.
Okay.
Thank you very much.
Thank you.
Okay.